It's time for the No Nonsense Roundtable. Insights to capture your imagination from people you know and people you'd like to know about. Each week, a different guest from a different walk of life. Now, here is the host of the No Nonsense Roundtable, Dom Genova.
Well, welcome everybody for another edition of your No Nonsense Roundtable. I'm Dom Genova, your host every Saturday, 10 to 11, right here on News Radio WHAM 1180. And I have a wonderful guest I'm sure you're all going to want to hear from. And his fellow's name is Jeremy Cushman, Dr. Jeremy Cushman, and he's involved with the county. And your official position is, well, you handle emergency services, EMS coordination, whatever. Let's give him the short form of what you do.
Yeah, I man of many hats, if you will. So I am an associate professor of emergency medicine at the University of Rochester, which is really my primary responsibility, but I get to provide medical direction and oversight to really all of our public safety entities within the county of Monroe. That's all the fire departments, ambulance services, our 911 center, our law enforcement colleagues, and so forth.
Well, you know, I was looking at your qualifications online, and it starts with MD, MS, EMTP, FACEP, and FAEMS. Could you explain all these? I'm not smart enough to know what this is.
Too much time in school is really what that means.
Okay, so we know what MD is.
Yep.
MS.
Yep. So I'm a physician. I have a master's of science in emergency health services.
Okay. EMTP.
I am still a certified paramedic within the state of New York.
FACEP.
FACEP is a fellow of the American College of Emergency Physicians.
Wow. And FAEMS.
And that is a fellow of the Academy of Emergency Medical Services.
If I had any doubt that that you were the smartest guy in the room, I mean,
hardly the case. Hardly the case, Tom.
So I am very, very, very interested. I think a lot of our listeners are too, about the dynamics of what's happening in the healthcare business, especially with emergency services. Sure. And how important that is. Now, we had somebody on a few weeks ago that has to do with EMS and ambulance service and whatever. But you know that's only the tip of the iceberg. I mean, let's explain what you do and the impact and the import of it all.
Well, you know, I think many of us come to take for granted that when we call 911 because we're unfortunately having a very, very bad day, or someone that we love is having a very bad day, that we expect that an ambulance will arrive. And in most cases, I think there's an expectation that, well, they can't really do anything except provide transport to an emergency department where the emergency department will do all the good stuff, if you will. And really the trajectory there has changed over the years. When I started in the early 90s, there was admittedly mostly what we would call a you call, we haul mentality, whereby we would essentially pick folks up and move them along. And that, I mean, goes back literally decades to where EMS originally came from, emergency medical services originally came from, which was just that, transporting people, not actually providing any clinical care. But nowadays, the clinical care that we can provide to someone in the field is just tremendous and can, in fact, alter their trajectory through the healthcare system that entire way. And so, obviously, I'm a little biased because this is what I've certainly dedicated my career to. But emergency medical services as a profession just is a uniquely challenging practice environment that has tremendous impact on people who generally are having one of the worst days of their life.
Well, it has to have a lot of effect on the people that you hire and their skill level, because if you're talking about picking somebody up and bringing them back, being basically an Uber, that's different than somebody who's going to be servicing them and doing cardiac work on them at their house.
Yeah, it's very true, and you know, for those of our listeners that are a bit of history buffs, you know, you really emergency medical services and ambulances have a very, very long history that in fact, you know, dates really all the way back to Napoleon. So Napoleon's surgeon Dominique Jean Leray, had really begun to do this process of, he coined them in a French term that I can't pronounce, but basically the flying ambulances. And what he found was that he could take Napoleon's injured soldiers and use horses to basically draw or drag them back to an aid station where there was a field surgeon. Fast forward into even the First World War, where they started to pull injured individuals back to a field hospital. And for that, even further, and we remember the Korean conflict, and some of us remember watching MASH, right? Where the life-saving benefit for victims of trauma to get to a mobile army surgical hospital, a MASH unit, dramatically decreased death and improved survival from some horrific injuries. Now, pair what was going on with the Korean conflict with what was happening in the United States during the 40s, 50s, and even early 60s, right? Which was the advent of the interstate highway system. And so we had, and you certainly appreciate this as a previous purveyor of fine automobiles, that you had this tremendous push on the roadways and a tremendous increase in road traffic deaths. Mm-hmm. So 1966 rolls around, and there's a lot of different things going on in the world, and the National Academy of Sciences was commissioned to develop a paper. And it was basically entitled Accidental Death and Disability, the Neglected Disease of Modern Society. And what this really was a call to arms regarding all of these people being injured in road traffic deaths. Mm-hmm. That spawned the Emergency Medical Systems Act through the U.S. Congress, that was passed in 72 or 73, if I recall, that really created the first EMS systems. And so what the federal government did is they gave out block grants around the country to say, here, develop an EMS system. And that was really focused on truly transport, literally picking up people and taking them to the hospital in Cadillacs. And because actually hearses were the only ones that could transport patients that were horizontal, if you will. So all of that was going on. And that was actually all overseen by the DOT, the Department of Transportation. And so that's really, truly where EMS got its start. And it really wasn't until truly you're getting into the 80s and 90s where you start adding paramedics and doing things other than just basically pick them up and haul them to a profession, and ultimately a profession that's been recognized within the House of Medicine. Not that long ago, it was only a decade ago that it was recognized in the House of Medicine as a bona fide subspecialty, just like a cardiologist or something else like that.
So it's sort of like the opposite of what's happened with the medical business all told. I mean, years ago, you would have house calls by a doctor, and the doctor would come and see you. Yeah. And now that doesn't happen anymore. And then you had an ambulance that would come and pick you up and bring you back. And that's not what happens anymore. Now it is services where you need them because it's so important to have them as quickly as possible. I guess that's it, right?
Well, some services do need to happen as quickly as possible. Some, quite frankly, could wait a little bit.
That's a good point. And we're about ready to head into a news break, and we're going to be talking about that when we come back. That's fascinating stuff. I never knew this. And we'll see you right after this. Well, welcome back. You're listening to No Nonsense Roundtable. We're here with Dr. Jeremy Cushman, who's in charge of healthcare services as far as they involve EMS. How would you word this, like, in a sentence?
I still haven't figured out how to do that. 20, 30 years in this world. The way that I look at it is that I provide the clinical guidance and oversight to our first responders.
An employee of Monroe County.
Of the University of Rochester. The county of,
okay. Let's explain that to people.
Yeah. So the University of Rochester. I'm an academic emergency physician, and I have the good fortune to have a number of different entities contract with the University of Rochester for the services of myself and some of my colleagues that provide medical direction and clinical oversight to counties, to municipalities, to fire departments, to ambulance services, and so forth around the Finger Lakes area.
Well, let's talk about the physicians that are interested in doing what you do. Is it a subset? Is it the emergency room doctor? I mean, tell me about, we all know about EMS personnel and what they do and at the scene of whatever problem it is. But when you get back to the hospital, are there some hospitals that are better than others, more equipped than others, have more doctors? I mean, explain what happens after the patient is left off.
Well, so we have to recognize that even in the emergency medical services world, only about 60% of the calls that we go on end up having the patient be transported to a hospital.
Really?
Believe it or not, yeah, right? So about 20% of total calls are canceled, meaning we can't find the patient. They never called for us. Somebody else saw somebody, I don't know, falling asleep on their phone in their car in the parking lot and called 911 because they were concerned about someone slumped over the wheel of a car. About 20% of calls for service, we take care of them in their house because they tripped and fell and they need some assistance getting up, or they were concerned about something, a symptom or sign that they had, and so forth. So only about 60% of our 911 EMS calls actually end up going to the hospital. And then going to the hospital, really the role of the EMT or paramedic is to not only provide that initial stabilizing care and treatment and so forth, but also to, in many extents, match a patient's clinical needs with the facilities that are available to them. Because to your earlier point, not all hospitals are created equal, and it has nothing to do with the professionalism or the doctors that are there. It's just simply that, for example, Highland Hospital does not have the infrastructure to take care of someone with what's called a ST segment elevation myocardial infarction. It's a big fancy word for a big heart attack that requires a cardiac catheterization immediately. So what the EMS system does is that if they see that someone is presenting with that, they make sure that that patient gets to, in our community, it would be Rochester General or Strong Memorial, or in some cases even Unity Hospital, that have those capabilities. Similarly, pediatric patients or trauma patients. There's only one trauma center in the entire region, which is the University of Rochester. And so someone that meets certain clinical criteria needs to go to that trauma center, because we know, based on research and science and so forth, that those patients will do better. Individuals with a psychiatric condition or a mental health crisis would be, depending on what's going on, may be more appropriately served at different facilities. So again, every hospital has some different capabilities, and most of those are determined through either accreditation or designation by either state or other entities so that, and then again, it's the EMS's responsibility to alter that patient's trajectory.
So is that decision made by the EMS ambulance? I mean, is that boots on the ground sort of thing, or is that done by a central location?
No, that's boots on the ground. So our EMS providers, EMTs and paramedics, in my estimation, and again, I'm biased, have extraordinary autonomy and challenge to be able to develop a relationship with a patient within seconds, sometimes in their home, on a street, anywhere, figure out what's going on with very few diagnostic tools other than the things between their ears, meaning the brain and the eyes, and developing that relationship, figuring out what's going on, provide whatever that life-saving care is, should it be needed, and then direct that patient through towards the facility that is most appropriate for them.
Well, so they have to have quite a bit of education. Now, how the people that are in the ambulances, the EMS people, how long is the training for somebody like that?
So that's both the scary part and the pretty amazing part, right? Is that these are amazingly skilled clinicians. An EMT generally is about 160 to 180 hours of training, which is it. Our paramedics, it's a couple thousand hours of training, time in clinical environments, learning different skills and so forth. and they can manage a tremendous amount of really bad things that happen to people. So they can manage effectively a cardiac arrest in a living room just as effective as I, as a physician, can do it in an emergency department.
What do you think is the most valuable asset one of these people have to have?
Well, I think there's a couple. Obviously, you have to be able to interact with people. So it sounds kind of obvious, but if you're not comfortable approaching and asking people questions and developing a rapport with an individual, it's a really, really tough job because you have to be able to do that both for your safety as well as figuring out what's going on with that patient that day. You have to be able to make quick decisions and that have very often not a lot of data in front of you. As an emergency physician, as a paramedic, I often have to make decisions with the absence of data because people's lives depend upon me making a decision to do something or not do something, not wait for a test to come back in a couple of hours when it's after the fact. You're
pretty confident of what the EMS personnel tell you when they come to the hospital, right?
Absolutely. I mean, it's an inherent trust that I would hope all healthcare providers have.
Do you get to know these guys?
I certainly do, and I think most of our EMS medical directors certainly do, because in many cases we're training them, we're teaching them, we're responding to calls out in the field with them.
Well, and one of the things, and we can talk about it after the break too, scheduling's got to be a problem because you might have a shooting and you have somebody with a couple of broken legs, and how do you do that because you only have so many resources and so many ambulances on the ground at any one point in time? That's got to be tremendously difficult for you.
Well, it's a challenge for a lot of reasons. Unfortunately, getting back to the financing of emergency medical services, it is based on a reimbursement model, and generally insurers will only reimburse if the patient is transported, not the level of their acuity. Because as I mentioned earlier, the history of EMS is actually as a transport.
Right.
Not as medical care. So it is still it's still under Part B of Medicare, for example. So it's considered actually a transportation benefit, not a healthcare or clinical care benefit related to that.
That's a fascinating concept right there.
It is, and honestly, it's been a big challenge to EMS because in some cases I may have an encounter with someone where they may not need to go to the hospital. But there's actually a disincentive to transport that patient to the hospital to be able to obtain reimbursement, when in fact maybe a more appropriate would be for me to connect you to maybe a nurse or a navigator or a telemedicine physician to help you get actually what you need, which may not be either me as a paramedic or an EMT or even the emergency department, because many times people are just calling because they need help with something and they don't know how to navigate, which is, I think, as we all know, an extraordinarily complex process.
Fascinating stuff. We're about to head into a news break, but I have a very important question when we come back about what people should know and not know when they ask for an ambulance.
Absolutely.
Well, welcome back. We're talking to Dr. Jeremy Cushman, and we're talking about EMS services in Monroe County. And for the people that are listening, when you have a choice or you have the decision to make a telephone call with something that's happening in your health at your home, what do you need to consider first or second or third? I mean, how should that decision be made? When do you know you need to call for an ambulance or just get in an Uber and go someplace?
Well, I think a lot of it is hopefully what we'd consider second nature, which is if you're that concerned about something, about a loved one, then you need to call 911. And the reasons for that are multifold. Again, I mentioned earlier that EMS has the opportunity to alter that patient's trajectory through the healthcare system. We know based on the data itself that you getting evaluated by an EMS provider because you're having chest pain, and we recognize that you have a heart attack that is amenable to a certain therapy, we can get you there and literally on the table faster than if you were to drive yourself, register, so on and so forth, right? So to a great extent, one of the important roles that EMS has is to triage and identify folks that have particularly a life or a time-sensitive illness. So strokes, heart attacks, as I mentioned before, cardiac arrest, right? God forbid someone collapses. We know that the things that make the largest difference in cardiac arrest are early recognition, bystander CPR, and accessing an automated external defibrillator. And so the sooner we can get that to bear is when we want to do that.
Well, how's crime affected the whole system? I mean, you see these horrible statistics about shootings and emergency services that people need and at times of the day and whatever, and that's got to affect the whole system all told. I mean, has that been a major change over the number of years, or is it just our perception that's a major challenge over the last couple of years?
I don't think it's necessarily changed. The impact on our ability to provide ambulance or emergency services directly. Indirectly, it continues to contribute significantly to the moral injury and the mental health burden of providing these services to the community. Emergency medical services personnel, along with our fire and law enforcement colleagues, see humanity at its worst. And those are experiences that, having been through, unfortunately, many of them myself, that never leave you. And there has been, particularly in all aspects of first responders, generally a bravado of hey, suck it up, Buttercup, and kind of move on. I think we're turning that corner now. In that we have more and more responders recognizing that they have to, number one, take care of their mental health. And sometimes that means involving professionals in that, because it is a very, very difficult job at times, because, again, you do see the worst of humanity sometimes. So again, I think it's indirectly related to that, but there's no question that the levels of violence that we see throughout our community, again, takes a toll on our responders that have to see that, have to interact with families and loved ones that are going through that as well, and it's hard.
So what you're saying, to paraphrase it, is that it's serious, but it's not affecting the overall. It's not so bad as affecting the overall level of care that you can give to the general public. Is that what you're saying? That's
exactly what I'm saying, and I think really when we look at it, we know that those that access the emergency medical services system do so for a number of different reasons, the vast majority of which is because they have something going on that they believe is life-threatening or potentially life-threatening. And those are folks that we still want to have call 911. But we also know that folks call 911 for all sorts of other reasons, because unfortunately they don't know where else to get that help. The mental health crisis that I think we are all experiencing, not just in emergency services, but as a public, we see the rates of mental illness, anxiety, depression, and others at soaring levels. We see the levels of substance use disorder at soaring levels throughout our communities. But we still have challenges in helping navigate at the individual level what might be best for that person at that point in time in their crisis to be able to find some answers, get the help that they need, get connected to resources so that they can hopefully be able to have a better ending than a beginning.
Let's talk about another thing that is in the news a lot is the thing about vaccines and if you're vaccinated, you're not vaccinated, who can work, who can not work. Give me a little bit of read on that whole thing.
Yeah, well, certainly there's a fair amount of controversy in that in terms of mandated vaccines and so forth. Emergency medical services generally takes its lead from the rest of the healthcare industry. And my guess is that you would see the same differences of opinion in the emergency medical services industry regarding the requirement of vaccine mandates. What I think is important to put into perspective, though, is that when I work on an ambulance, and I still do that actually a couple of times a month, I am putting myself in people's homes, in their bathrooms, in their like wherever they happen to be. And then I'm putting them in roughly an 80 to 90 square foot box.
Right.
Called an ambulance,
Yep.
right? Which doesn't have great ventilation, and really exposes me to those things. So my approach to my colleagues in the emergency services world is that, hey, anything that we can do to minimize our occupational risk, it's no different than me wearing eye protection or gloves to reduce my risk of contracting this is a good thing. And currently that includes the use of masks. As we've seen, the healthcare world continues to wear masks in clinical care settings. We continue to advocate for our providers wearing masks because it's more about, at this point in time in the pandemic and all of protecting ourselves than it is necessarily our concern about being a vector for transmission to those that we care for.
Well, because of the stress involved with the jobs, you see a lot of people exit with COVID. I see, I see.
Oh, yeah.
I see the look in your eyes with that one, huh?
No question, right? So you look at New York State numbers. Last I saw, in the last 4 years, there's been a 27% decrease in EMTs, certified EMTs and paramedics in New York State. Add to that at baseline, so even pre-COVID, emergency medical services experiences on average about a 25% per year turnover rate. Right, so you do the math, right? Right, every 4 years,
especially when people need training. Yeah,
correct. So it is the turnover in the industry is a lot, because I think most people don't see it as a long-term career in healthcare, because it's hard, and most utilize it really as a stepping stone to other careers in medicine, whether it's nursing, PA, nurse practitioner, physicians, and so forth.
Well, the thing about the job is that it's one of those jobs that at the end of the day, you know you did some good for somebody. But it's hard, to paraphrase what you said, to unsee something that you've seen during the day.
That's absolutely right.
Yeah. Well, we're about ready to head to another break, and we'll be right back, well, after the break. Well, welcome back. We're talking to Dr. Jeremy Cushman, and I'm looking for a short way of explaining what you do. Give me that one sentence again.
Yeah, I provide clinical guidance really to all of our first responders throughout the time.
Monroe County.
Yeah, Monroe County, even some of the surrounding counties, from the time that you call 911 to the time that you get to the hospital.
And it's got to be a rewarding job. But we were talking before about EMS responders, and at the end of the day, you go home and you did some good for somebody, which is really kind of a neat thing. But there's things that you can't unsee, and you carry with you for the rest of your life, I'm sure. Yeah,
and I think one of the other challenges with being an EMS practitioner is that you don't always see the instant results. So take, for example, if I have someone that has a misadventure with a knife while cutting their bagel, right? And they have bleeding all over the place. They call 911. We get there. We provide care. We see the bleeding stop. The patient's happy, et cetera. We get them to the hospital. They get stitched up, and life goes on. We have immediate gratification. We provide CPR, and we use a defibrillator, and we get pulses back. We get a heartbeat back. Instant gratification. There's so much that EMS providers do that they don't see the immediate results of. So take, for example, there was a study that came out a couple of years ago that looked at how our EMS providers ventilate someone with a head injury, meaning what they do is we use a device to be able to breathe for the patient. And this study basically demonstrated that if our EMS providers are paying attention and doing some very, very, what we would consider simple things very well, that even though their time with EMS was on average, I think it was 18 or 19 minutes, that the impact on that patient's outcome, that there was a 2 to 3-fold improvement in what we care about, which is neurologically intact survival, which is means that I can go home and feed myself and kiss my wife and play with my grandkids and do all of those other things. And when you consider that patient had a healthcare experience that on average was a little over 2 weeks long, but they were only with EMS for 20 minutes. And what EMS did in that 20 minutes when they changed some of these things was able to see a 2 to 3-fold improvement in outcome. There's not much in medicine that accomplishes that.
Right.
And so that's what's so cool about it, which is in many respects my responsibility to help educate and inform our EMS providers on what you do really does make a difference, even if you don't see it within seconds of you doing it.
Well, you're talking about that moment in a football game.
Exactly.
Right?
Right. And so, we all, millions and millions of people saw what the American Heart Association and we have all been calling the chain of survival for the last many, many years, right?
Right.
Which is, we know what improves cardiac arrest survival. Witnessed. Well, we had a few people witness it, right? We had immediate bystander CPR, which we did. I think somebody counted, it was like 72 seconds or something, or less. We had early defibrillation, and all of that stuff resulted in, quite frankly, what we would expect for a system to work like that. Now, obviously, it would be great if that would happen to every person that experienced sudden cardiac arrest. But I know even in our own community, our rates of bystander CPR are about 25 to 30%. And we as a community need to get that up if there's any chance in us being able to help each other.
Well, if there's any dramatic example of the change, there it is. 30 years ago, you would have had an ambulance that was, like you said, was a Cadillac.
Exactly.
It looked just like a hearse. There was a stuck Hamlin in there and taken him to the hospital and drove fast, and he wouldn't have survived, right? More than likely would not have survived.
More than likely wouldn't have survived. And actually, Dom, that brings up something else that I think is important for our listeners to understand is that, if someone is concerned for themselves or a loved one, I would never say don't call 911, right? We want you to call for that help. But also recognize that we have established processes that when someone calls 911, we ask them a series of questions to basically triage, to differentiate, is the person not breathing or do they have an earache? And we send different resources based upon whether they're not breathing or an earache for reasons that I hope our listeners would find obvious. But the other thing with all that is that we don't always respond with lights and sirens to the house, because what we know is that the risk of being in an accident on the way to the house is 50% greater if we are using our lights and sirens, when we know that on average, it is only going to save between 90 seconds and 3 minutes in response time. Yeah. So now there is obviously a place for those where we believe that there is a life threat, but if there isn't, we're not going to rush. Same thing on the other end. If you transport someone to the hospital, the vast majority of the time we do not send the patient to the hospital lights and sirens. And really the use of lights and sirens is actually what I would consider a clinical intervention, because what we're doing is we're saying that there's a 2 to 3 minute savings in time, and then there's risk. So the risk of transporting a patient in the back, lights and sirens to the hospital, increases the risk of an accident 300%.
That is a great point. That is an absolutely fantastic point, because when you're driving down the road and you see an ambulance, it might be doing something very, very important. It's good for you to get them up right away or whatever, and not just think that they're driving around and they're purposely not having the sirens on because it's safer. I never thought about that.
It's absolutely the case. And our region has been incredibly progressive in this approach because we know that it quite frankly saves lives by not having ambulances and people, innocent bystanders that are just driving to the grocery store, get in an accident as a result.
Right.
So the public service announcement there is please yield to emergency vehicles. But
with the lights off,
not even with the lights off, but when the lights are on, to recognize exactly to recognize that we may come or go without lights, and it doesn't mean that we don't care about the concern. It's that we have to weigh those risks and benefits.
You're doing it on purpose. So we only have about a minute left here, a minute and a half maybe. Let's talk about careers in EMS services. I mean, one thing I talk about all the time is marketable skills. You have a marketable skill, whether you stay as an EMS individual or you go on to nursing or something like that. Let's talk about that a little bit.
Yeah, no doubt. Like I said before, that's how I got started. I got started in college as a volunteer EMT and decided that this whole medicine thing was actually kind of cool, and I really enjoyed taking care of patients. It is a tremendous primer on truly basic life-saving skills, and how to assess and how to evaluate and really how to see the healthcare system. You see every aspect of the healthcare system being involved in emergency medical services. It's a hard job, but at the same time, it can be extraordinarily rewarding. By being able to serve your community, be able to serve others, and provides really foundational experience that can translate, again, I would argue, to any aspect of a career in medicine, or quite frankly, for you to determine that, you know what, this isn't it for me. I think I'm going to go somewhere else. So whether you're an EMT and you decide to volunteer or get a job doing that, it's a great opportunity for so many.
So if somebody wanted to, if somebody had a child who might be interested in this, our listeners are most naturally a little bit older, how would they go about that?
Yeah, I think the first step is really to reach out. All of the agency, all of our listeners have an ambulance service that provides care to their communities. So figure out who that is. Reach out, ask. You can go to Monroe-Livingston's Regional EMS Council website, which is the regional coordinating entity. It's mlrems.org, melrems.org. And that's a source of information as well. And so many of our community ambulance services are more than willing to lend an ear and to provide some opportunities to learn more about the industry.
Well, Doctor, I have to tell you, I learned a lot today, and I think if I learn one or two things, I think our listeners also learned one or two things. And thank you for coming in. This is fascinating stuff. I really do appreciate you coming in.
Thank you, Dom. It's been a pleasure.
Oh, we'll have to have you again.
Look forward to it.
Thank you. Well, thanks for watching this YouTube. If you liked it, please like and share.